Thank you very much. My name is Eugene McCloskey. I'm Professor in Adult Bone Diseases at the University of Sheffield, and it's an absolute pleasure and honour to be taking part in this meeting in Ukraine today. Over the next 20 to 30 minutes, I want to talk to you about FRAX and particularly the updates in FRAX that have occurred recently, and then I look forward to answering your questions. These are my disclosures. So FRAX has been with us now since 2008, and the original intention for FRAX hasn't really changed. It's a tool that's to be used in widespread clinical settings to allow doctors with lots of experience in other diseases, but working in many different healthcare settings, some of them within hospitals, but many within the community, within primary care, to provide them with access to expertise and advice about the assessment of fracture risk and the management of that fracture risk. So osteoporosis is a common disease, as we know, and it's largely going to be managed by family doctors in the community. The tool allows you to integrate information about risk factors to produce numbers, the probability of a major osteoporotic fracture in the next 10 years, the probability of a hip fracture in the next 10 years, and that then allows you to usually interact those numbers with local guidelines to decide about treatment options. Why did we need FRAX? Well, just a brief background to the development of FRAX. We've known for a long time that bone mineral density, measured by a variety of techniques, but obviously mainly by DEXA in clinical practice, has a strong relationship with fracture risk. And this is shown in this slide. The orange bars are looking at the fracture rate. And as we move to the right of this slide, the bone mineral density is decreasing, and you can see a nice stepwise increase in the fracture rate. However, although the people at the right-hand side of the slide are at very high fracture risk, there's actually relatively few of them in the population, so that most fractures are actually occurring in patients who sit within the middle of the distribution. And many of these are not within the osteoporosis category as defined by the WHO in 1994. Their T-scores are above -2.5. The question then is, well, what other risk factors can we add in to BMD to identify within that segment of the population those who are at increased risk of fracture and target treatment accordingly? That stimulated a whole body of work that resulted in a series of meta-analyses that were published in the early 2000s, looking at various risk factors and the relationship to future fracture. We started off with bone mineral density, and this is just looking at the relationship between femoral neck bone mineral density, the relative risk for a hip fracture in the future per standard deviation decrease in bone mineral density. And many of us will carry around in our heads that the increase in risk is roughly 2.6-fold for every standard deviation decrease in femoral neck BMD for hip fracture. That's represented by the green line on the graph here, but you can see that that relationship is not constant across age. The gradient of risk is higher at younger ages and lower at older ages, so that we can combine age with femoral neck BMD to enhance fracture risk prediction in individuals. In addition to the BMD and age, there are other factors that we can add in. Gender, of course, is an important impactor on fracture risk, but we also know that prior fracture, family histories, particularly of hip fracture, current smoking, glucocorticoid use, alcohol intake, and when we built FRAX, the only cause of secondary osteoporosis that we had enough data on to look at individually was rheumatoid arthritis. And in this slide, you can see in the grey bars that each of these risk factors is an independent risk factor for fracture. And in the orange bars, when we adjust that relationship for bone mineral density, each of these factors remains a BMD independent contributor to fracture risk, so that we could combine these risk factors with bone mineral density, with age, with gender, to enhance the fracture risk prediction in an individual. And this is the current FRAX tool. This is the tool that was launched in 2008. You can see that it's a fairly simple online questionnaire that captures the risk factors that I've just mentioned in the previous slides. We know that the fracture risk varies around the world, so that one fracture risk assessment model cannot be used in all the countries in the world. A woman, for example, at the age of 65 with a prior fracture in China will have a different fracture risk than a similar looking individual in Australia or North America or Europe. And that's why we've had to develop currently to date 81 country or territory models of FRAX, each calibrated to the epidemiology of fracture and mortality within that particular country or territory. So FRAX has become very widely used. This is just a snapshot of the FRAX website from earlier this year in April. And at that time, we have a counter in the bottom right of the slide here. And we had just under 42 million calculations worldwide since the launch of the tool. Well, actually, since we put the counter on in June 2011. And the online tool is used for about 3 million calculations per year. But we know that many, many more are done on the tool, which is embedded in the DEXA manufacturers such as HoodLogic and GE Lunar and others. So the availability of FRAX actually provides a number of strengths to osteoporosis management, but also a number of limitations. And I'll come back and talk about the limitations in a moment or two. One of the strengths is that it has been linked within many national and international guidelines to the management of osteoporosis. And on this slide, I'm just showing an example from the UK model. So the left-hand side of the slide is looking at the UK FRAX model. I've entered the characteristics of this 70-year-old woman to the FRAX calculation. She has no risk factors apart from being 70. She's got a BMI of 25 with a femoral neck T-score of -2. And that gives us major osteoporotic fracture risk of 11 and a hip fracture probability of 2.3. And on the right, then we have just some graphs, not for this particular individual, but on the right, we have graphs from the UK National Osteoporosis Guideline Group website. And in the UK model, we can take the results straight from the FRAX calculator to the National Osteoporosis Guideline site and plot the individual results on traffic light graphs that enable the primary care physician or primary care health professional to make decisions about whether this individual might need a bone mineral density measurement, or whether they should be considered for treatment, or whether they should be reassured. But I want to focus really on the limitations of FRAX, and it was designed to be a simple tool, but we were also limited by the availability of data at the time that we wanted to build the tool. So as you'll know, we have dichotomous variables for many inputs such as glucocorticoids, smoking, prior fracture, that take no recognition of the dose that's administered. So we don't capture the higher doses of glucocorticoids. We don't capture those who smoke excessively. We don't capture those who have had more than one prior fracture, or they may have had 2 or 3 prior fractures, and so on. And I'll come back to that. Some variables are not considered directly at all, such as diabetes, falls risk, lumbar spine BMD, trabecular bone score, not within the FRAX tool itself, at least. And then other factors, and one that's been getting a lot of attention recently, is time dependency following a fracture. And as we'll see from some data in a moment or two, we know that the increased risk of fracture following a fracture is particularly high within the first 1 to 2 years after that sentinel fracture. Of course, we can ascribe limitations to FRAX, but we shouldn't forget that we can ascribe limitations to all the techniques that we use in clinical practice. So we've used bone mineral density measured by DEXA for almost, well, over 30 years now. But of course, if we just base all of our clinical decision-making on BMD, then that ignores a host of information from all these other risk factors that are not captured within the bone mineral density measurement itself, such as age, glucocorticoid use, and so on. And also, it is sometimes difficult to interpret. There may be weight changes, there are difficulties with image quality, and so on. And so there are limitations to all the techniques that we use, and that's just really something that we need to recognize within clinical practice and then try to accommodate it as best as we can. So earlier this year, we responded to requests by many of the FRAX users to try to accommodate some adjustments to the FRAX probabilities that would take account of additional information that might be available about the individual patients. And in the FRAXPLUS version that we launched back in April, we now have 7 adjustments available. You can see on this slide that we can adjust according to the recency of fracture. We can perform an adjustment according to the dose of glucocorticoids, to the TBS value, to the duration of diabetes, to the presence of falls within the previous year. We can adjust for the differences between femoral neck and lumbar spine BMD T-scores. And finally, if individual units measure hip axis length, then there's the ability to adjust for the information that arises from measuring that parameter. FRAXPLUS has a number of other features. You can set up a FRAX Plus account, which you can do for free. There is a charge for the adjustments currently, and that charge can be bought at an individual level. That is something that is being coordinated through the International Osteoporosis Foundation, but they're very open to approaches from various healthcare settings to seek other solutions to how the adjustments might be funded. But without paying for the adjustments, you get access to a user account. That user account builds a spreadsheet behind your account that records all of the FRAX calculations that you do, and FRAX itself remains free at the point of use, so you can record all of the FRAX calculations that you do. You can export those results, you can set up email features to share individual results, and you can synchronize the account across different devices. So there's some of the additional features of FRAXPLUS. So to focus on one of the adjustments that has got quite a lot of attention over the last few years is the recency of fracture. These two graphs come from an analysis of an Icelandic population-based cohort where they were followed over several decades. And then we identified groups that had sustained a sentinel fracture. And on the left-hand graph, we're looking at those who had sustained a hip fracture, those who sustained forearm fractures, spine fractures, or humerus fractures, and then looked at the course of recurrent fractures in all of those who had recurrent fractures. So you can see over 10 years, 100% had sustained a recurrent fracture. But of those recurrent fractures, you can see that the majority of those occur within the first 2 to 3 years across the fracture spectrum. It's particularly high for hip fracture and spine fracture and humerus fracture, but somewhat lower for forearm fracture. And again, that's just reflected on the right-hand graph, looking at the hazard ratio. Within the first few years after the fracture, you can see that it's high, it decreases over time, but it remains above 1, which would be going back to the pre-fracture or population level of fracture. And we know that fractures confer an increased risk of fracture in the long term, as well as a particularly increased risk of fracture in the short term. So that allows us then to develop multipliers that we can apply to FRAX probabilities to adjust for the recency of fracture. And sadly, the multiplier is not a single number. It varies between men and women. It varies across the age spectrum, as we can see on this slide, and it varies across the site of the recent fracture. So, for example, for vertebral fractures, you can see that the multiplier that would be applied to the FRAX major osteoporotic fracture probability, if this was a woman at the age of 50, the multiplier would be 2.62. Whereas if that woman was the age of 90 years, the multiplier is only 1.02. 0.01. So the multipliers are age dependent, they're gender dependent, they're site of fracture dependent, and that makes the adjustment somewhat more complex than we might like. So what we've done is to incorporate FRAX into FRAXPLUS that allows this additional option of carrying out an adjustment of the FRAX probabilities based on that additional piece of information. So for example, here we've got a 65-year-old lady. Her BMI is 30. She's had a previous fracture. She's a current smoker, but no other risk factors. And her 10-year probability of fracture of major osteoporotic fracture is 17%. This is using the UK calculator. And for hip fracture, it's 5%. So on the UK calculator, again, you can see that we have the option of viewing the NOG guidelines, carrying those results through to the NOG guidelines and seeing what we might like to do. Or you can adjust the results by using FRAXPLUS. And if we click on the if we click on the NOG guidance, first of all, you can see that this 17% major osteoporotic fracture and 5% hip fracture probabilities are carried through to the NOG website. For the major osteoporotic fracture probability, this patient is on the cusp of treatment or reassurance and lifestyle advice, whereas the hip fracture probability puts her fairly firmly within the treatment bracket. And we always advise our users of the guideline to use the highest risk guidance, so the treatment will be recommended here. If, however, we wanted to take this lady through to FRAXPLUS, then she wasn't on glucocorticoids, so we don't have the availability of an adjustment for the dose of glucocorticoids. But she did have a recent fracture, or at least she had a prior fracture, and if we ask her and that fracture was within the last 2 years, then we can treat that fracture as recent and bring that through to the FRAXPLUS website. And in this particular case, it was a humeral fracture. So we just click the button for humeral fracture, and it was 12 to 24 months before this assessment. We put in those two pieces of information, click on the adjustment of the probability, and we then get a sheet that summarizes all of the information that we've put into the model for this particular individual. And that's important because that allows the user, the clinician, to look at all the feedback of the information that's put in, just in case there's been an error in entry of the data. So this lady has had a prior fracture, she has current smoking. Those are the two risk factors that we entered to the model. At the bottom right, we see the major osteoporotic fracture and hip fracture risks from the original FRAX calculations of 17% and 5%. But on the bottom left, we see that we've subsequently adjusted that probability according to a recent humeral fracture that occurred 12 to 24 months ago. And then on the right again, we see the adjusted major osteoporotic fracture probability. That's increased from 17% to 26%, and the hip fracture has increased from 5% to 7.5%. And again, if we take that through to the NOG guidance, we can see that this lady is now not only in the treatment category on both measures, the major osteoporotic fracture and the hip probabilities, but now is on the cusp of or lies within the very high risk category, and should be considered within the NOG guidance for specialist referral and treatment, including consideration of bone forming treatments. So that is just a brief introduction to FRAXPLUS. What about FRAX itself? Well, when FRAX was first launched in 2008, it was built on a relatively small number of cohorts. We had just under 200,000 person years of follow-up. Just over 2/3 were women. And you can see that in total outcomes, we had 850 hip fractures and just over 4,000 osteoporotic fractures. Over the last 2 to 3 years, we've been collecting together data from updated cohorts from around the world. We now have access to 64 prospective cohorts, and that includes a total of just over 2 million men and women. We have approximately 10 years follow-up in most of those cohorts. So we've got about 20 million patient or person years of follow-up. And we almost have as many hip fractures, incident hip fractures, as we had total number of people in the original FRAX model analysis. We now have just under 200,000 incident osteoporotic fractures. So that's going to allow us to not just look at new variables that might enter into FRAX, but also look at refining the coefficients for the existing variables within FRAX, because some of those variables maybe have changed over time. We now have a much wider geographic distribution, and even though the gender distribution is still predominantly female, we have a much larger population of men to examine these risk factors within men in more detail. So that's a body of work that is ongoing. There's lots of additional risk factors that we might consider in an update of FRAX. As you can see, some of these relate to other aspects of the musculoskeletal system, so particularly around muscle strength. So we're looking at considering things such as chair stand tests, gait speed, grip strength. Previous falls is very easy to find or to inquire about in the clinic, and so on. We're also going to be looking at more diseases associated with the risk of fracture, such as Parkinson's disease, diabetes, and so on. So it's really an exciting time, a busy time that will lead to a new version of FRAX in the next few years. So just to summarize, over the last 15 years, FRAX has become an established clinical tool. It's very widely used in the assessment of fracture risk and in treatment decision-making. Like all the tools that we use, not just in bone disease, but tools in other disease settings, FRAX has limitations that are well recognized, acknowledged, and are starting to be addressed. So through FRAXPLUS, we're actually able to modify the information that is provided around existing risk factors within FRAX. And we've also been able to add in some additional risk factors such as prior falls and so on. Of course, we have to recognize that this evidence base is not built on the number of cohorts that FRAX itself was built on. Frequently, these adjustments come from one or two cohorts. So we just have to be a little bit cautious about over-interpreting the impact of these adjustments. And that's something that we will continue to work on over the next few years as well. The next generation of FRAX, we hope, will include novel and updated existing risk factors. That's being developed. I really would like to thank you for listening to the presentation. I look forward to any questions that might arise. I also look forward to your feedback from using FRAX and FRAXPLUS. The FRAXPLUS is a beta version that we want to develop with feedback from our users. So thank you once again for listening.